My name is Sean FitzGerald. I'm speaking to you today from Jasper, Alberta. I'd like to begin today's webinar by acknowledging that the College of Physiotherapists of Alberta's offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. The College of Physiotherapists of Alberta recognizes that Indigenous peoples have been helping many live healthy lives on this land long before settlers arrived. With that, we commit ourselves to helping move people forward in their journey towards a good life and doing so in a way that follows the spirit and intent of treaty. That is peace, friendship, and understanding. We also recognize that people from across Alberta and beyond are joining us today and encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. It's my pleasure today to welcome Matt Goertzen and Jacky Chow. Jacky is an associate teaching professor with the Department of Physical Therapy at the University of Alberta. Jacky is also a practicing physiotherapist at the Foothills Medical Centre. Matt Goertzen is an assistant lecturer and clinical supervisor at the Faculty of Rehab Med, the University of Alberta, and Matt is also the team physiotherapist for the Edmonton Oil Kings and is a mentor physiotherapist with Hockey Alberta. Welcome, Matt and Jacky.
Thanks, Sean.
Thanks for having us.
All right. Okay, so we're actually going to start this off with the polls. So for those in attendance, we'll get you guys to go through the polls. There'll be 6 questions, which you guys can go through and answer. As you guys are going through the polls, we'll kind of introduce kind of what we're doing here today. So for those of us that were at the Alberta Association of Physiotherapists conference in Canmore, Jacky and Matt hosted Ethics on the Rocks. It was a Saturday evening kind of presentation where various kind of ethical questions were posed. People had a chance to go around and put sticky notes of their answers, kind of similar to what you're doing. Rather than yes or no, it would be more qualitative, so looking for comments on the scenarios. So for you guys, like, did you guys come up with those scenarios on your own, or was there other kind of sources that you drew from?
Yeah, it was kind of a combined effort. So we kind of just thought of things like, so Matt and I, we run various seminars kind of related to this in class. So, the idea came to us just thinking, this would be so fun to do with clinicians. So some of those questions came from things we've done in class and then just other things we've kind of heard in the community.
Yeah, and I would kind of say, like, with some of the responses that we'll discuss today, like, I think kind of it is good to frame around. There was quite a few clinicians in attendance for sure, but there was a good chunk of your students that showed up as well, which I think kind of lent to a few interesting kind of answers that came up, which may or may not be quite I think representative of what the clinicians in the audience probably would have written down as well.
Yeah, I think it was a super interesting dynamic. Because I mean, we have these discussions with students all the time, and they haven't been in a clinic, they haven't experienced these things, so they're just kind of like taking our word for it. So to kind of fuse those groups, and then like we figured we wouldn't have great attendance if we did an ethics session during the day, so we took over cocktail hour. So that really helped us as well. I think getting people talking and having a little bit of fun with answers. And yeah, I think a big chunk of devil's advocacy for sure.
Yeah, that's definitely worth pointing out where even when we introduced the topics, we sort of said that, like you may think a certain way, but by all means, play devil's advocate, have fun with it, have some discussions. So, the answers we got, it's hard to know exactly what was truly representative in what people would do and what's just sort of conversation starters.
Yeah, and I think it's good. And I mean, we'll kind of do that a little bit today too, playing a bit of devil's advocate as we go through the scenarios. I mean, we do want to kind of have clear direction at the end as, the things that we want to point out to the physiotherapists in attendance and the ones that are going to be watching later on YouTube. We do want to make sure that they do know what at this stage, what the college's perspective is on those things and kind of point them in directions which they can find answers to see if what they're doing kind of meets the standards of practice and code of ethical conduct. But I think for the purpose of what we do today, yeah, we'll want to kind of play both sides and hopefully just come up with some good discussions around it. And hopefully people find that informative and kind of well worth their time for coming in today. All right, so I guess that being said, the polls are done. So we can rewind back to these as we go through. So I'm just going to end the poll now. And then we're going to share the results. All right. So we'll go through this as time goes on, but for the most part, I'm gonna hit the stop sharing now because I think this is on the middle of everybody's screen, I'm guessing. So we'll slide that off. Okay. So, first question. So, I guess first sticky note of the day. A clinician has their diagnostic imaging certification, orders private MRIs paid for by insurance, and for all of his individuals with neck pain after motor vehicle collision, is this acceptable practice? So, we had 26 people respond. 2 responded yes, 24 responded no. So again, let's kind of open up for discussion. So what would be kind of your guys' thoughts on why you may do this or why you may not be doing this?
Matt, you want to go first or you want me to start?
Sure. Yeah, I could dive right in. I mean, I think the discussions that we have a lot in physio practice and the discussions we have with our patients and our colleagues, we're always dissecting diagnostic imaging in the clinic. We're always trying to like teach our patients the relevance of that. Something that goes hand in hand with that struggle is that a lot of patients really want really high level diagnostic imaging, so an MRI. So there's always that pressure. My neck really hurts. I got a motor vehicle accident. I want to know what parts are busted. Like I want that information for myself. That can happen really, really quickly with a third party payer. So you can see why that would be extremely tempting as a clinician. You can see why, especially if you're a clinician that takes a super pathoanatomical approach to spinal pain, how you would want a specific pathoanatomical tissue that you can point out to your patient. And I mean, we're living in a world where you can do healthcare tourism, and I mean, you can pay a bunch of money and get a full body MRI, and you can get a full report, and you can get a bunch of blood work and get a full blood panel. So I have to think that when I poached this and slightly bastardized it from an actual statement that a physio had made, a practicing physio had made, I have to think they're coming from that lens that patients want this. I can get better patient buy-in. I know that my rapport with a patient is critical to my patient success. So why the heck not? What do you think, Jacky?
Yeah, for sure. Like when we're thinking about the pros and cons, like the pros, like you listed right there, right? Like to have that gold standard at your fingertips and you've done the training and you feel like you can kind of, put the people in the bucket where you think they do need the MRI. It's tempting, right? It's right there. And the reality is that financial aspect of it is such a key part, right? Where you're not asking the patient to pay for it. So it does feel a little bit more removed, that financial part of it. But yeah, definitely. Obviously, there's a lot of things against it. I don't know, Sean, if you want to get into that to start with.
Well, I think kind of, the Choosing Wisely campaign is probably, I think, the best viewpoint from this. So there is quite a lot of research that would support not doing this, looking at the pathoanatomical kind of viewpoint, there's lots of research that shows lots of people have junky stuff in their neck on MRI anyways, even prior to that MVA. And do you really want to go down that road of kind of pointing that out to the patient? You get some fear avoidance belief kind of stuff built in. So I do think kind of using the Choosing Wisely campaign is a great place for clinicians to start, because there is a lot of research that shows that this isn't a great road to go down. And I don't know, kind of, you guys, when you work clinically, like we've all had those patients too who they show up with the MRI and they've got, a list of issues that have popped up, and, they're already kind of going down the Google rabbit hole of all these horrendous things that can happen to them because they have a disc bulge or they've got, some arthritic changes at C5, C6. Like those aren't, anomalies by any stretch, but now you've given them something that you can kind of latch onto that doesn't necessarily alter your clinical decision making and how you're going to treat. Their treatment plan may not differ at all. Yeah, I don't know, kind of when you guys think about stuff like that, like on the why you wouldn't kind of be ordering all these things, like anything else you want to add?
Yeah, definitely that fear that it can bring onto patients unnecessarily. That's a big part of it. But there is that other part for the in favor of it that I can understand, right? Like whether it's personal experience or patients we've seen or just stories we've heard where every once in a while there are those scans that may not have been necessary, but they do catch something and it turns into something bigger. And it's hard to kind of like let go of those stories sometimes when you have that, when you feel like, oh, I could have actually ordered it and prevented it. And you're just thinking of those catastrophic, very rare but events, and it's hard to kind of put those aside sometimes, I think.
Totally. And I think that when you look at it from a purely when you zoom out a little and you think of how the vast majority of people in the community receive MSK care, specifically post motor vehicle accident, it's private. It's a private business. So it's pretty hard. As much as we can sit here and we can say like, well, this seems unethical and like you're compromising patient care for money. There's a lot of money attached to these MVA patients, right? Like these MVA patients to a private clinician, they can be a cash cow. So do I understand why this exists? Absolutely. Do I understand why this is a huge risk for patient care? And do I greatly oppose the use of this? Also, absolutely. But unfortunately, it's a byproduct of the fact that our access to physiotherapy is often directly tied to profit motive in 2025. So it is a challenge that I think will persist. I think as long as our physician colleagues aren't necessarily choosing wisely, that kind of buries us a little bit as well, because that hierarchical, well, my doctor ordered me imaging, like why wouldn't you? It still kind of persists, unfortunately. I think it's getting better, but I think it's still, those things are still a big problem for us.
Yeah, and when we look at at least the response to the poll, I mean, we had, 95% kind of say that no, they don't believe this is, the way to go. And I think really when you look at the numbers that we're looking at, like if you're, 25 for 25, like you at that stage, I think have abandoned clinical reasoning and clinical judgment. Like you're not really looking at that individual patient who walks in your door to be like, okay, like, do you have red flags? Like, do you have yellow flags? Like, is there anything that makes my spidey sense tingle that there might be something sinister going on? And, so I think kind of when we look at, that scenario and you see the numbers that are going through, like, it really doesn't really point to kind of that idea that you're actually like individually assessing and making clinical opinions based on what the presentation is. You're just like blanketing like you get an MRI, you get an MRI. Like, it's
You're going full
like,
Oprah. Yeah.
oh, totally, yeah. You've kind of, I think, abandoned kind of that thought process, which makes us, I think, evidence-based physiotherapists.
Yes.
Okay, so I think we'll carry on to the next one. So,
Great.
sticky note number 2, community organization is a voting competition to crown the best physiotherapist in the city. Physiotherapists now using this in their social media and marketing. What are your thoughts on whether or not this is a legitimate way to advertise your practice? So when we look at the polls, this one was a little bit more split, 80-20. So 20 said yes, 80 said no. Jacky, do you want to start us off?
Yeah, sure. So this one, like I know the college rule, so that's one thing. But even just kind of taking the perspective of it, it does seem like kind of taking the side in favor of it. It does kind of seem like a fun way to promote physical therapy. Kind of it could be a way to just kind of get people engaged in it a little bit. And then just the idea of being best, I guess it'd be interpreted as sort of an opinion. And of course, everyone's entitled to their opinions. And so, I think there's some room there to kind of to see why people would be okay with this sort of thing.
Yeah, I 100% agree. And for me, that's comes back to the previous point. Like we are we have a lot of private clinicians in our practice, and they want to advertise like they're a private practice. They want to advertise like they're selling the best hot dog in town. Like they have the best hot dog stand. Their mustard tastes better. So like again, I get it. Like I get how you want to be the best. The other thing is that as physios, we're super competitive. Like that that is kind of ingrained in our nature. So like I get why this exists. I think the challenge that I have with it is um there's so much political pulling behind the scene. So if you know that this contest is coming up, you put you put a sign on your front door that says, "Hey, vote for us." It's great marketing for you, but has that patient gone to all of the other nominees? Like, what's the validity of that opinion? Like, I get everybody has an opinion, and heck yeah, like express your opinion, sing it from the rooftops. But like, we're not judging based on merit in this case. We're judging based on politics and who puts the most money into their search engine optimization and who has a social media manager. So I think it's muddy. And if we want to position ourselves as specialists in healthcare, I think it just kind of debases us a little bit.
Yeah, because it really comes down, I think, said the, you know, the truthfulness of it is really kind of what are you basing this on? Like, is there really like a good, like, does there really even exist like a good qualitative way right now to like pick between clinics and be like, you know, oh, like you guys have really good outcome measures. Like we don't publish our outcome measures, so it's really hard to kind of come back to that and be like, oh yeah, like ankle sprains, this clinic like owns it. They're really good. Like look at all these, you know, when we can compare like across. So really like the best, and it's like, well, who did you ask? Like my mom for sure thinks I'm the best physio. You know kind of where everybody else lies. But I mean, I think kind of generally it's hard to really, you know, get like a solid like, yes, for sure you should be there. And I think that's where, you know, the college kind of comes to that kind of conclusion is, you know, really kind of for advertising, it has to be, you know, truthful, accurate, verifiable. And, you know, unfortunately, like those best of, best in don't really meet it. I'd say like the other one is the fact that oftentimes like you can kind of buy the best in kind of badge, right? Like I don't think oftentimes it's really like based on any sort of, I mean, for sure, Chamber of Commerce, like the local newspaper, they'll put a poll out, but sometimes you see the best in, you know, best in Calgary, best in Edmonton badge. Like don't really know how much really that is based on anything that's anybody is even pulled out, or is it just, you know, something that you've kind of copy and pasted onto your website?
Hey, Sean,
Uh,
can I ask a question that's kind of related to that? Like,
sure.
what if you're like throwing like your Google reviews, you got 5 out of 5, that sort of thing. Like, does that sort of fall in the gray area?
Hmm.
Yeah, it's a good question. I think kind of with those, I think again, like you're you can't well, part of it is one, like you can't really control what gets said on Google, and that's like a positive and a negative, right? You can get people, and generally the people who don't like your hot dog are going to speak the loudest, and the ones that love your hot dog oftentimes don't say anything. But yeah, if you're, you know, if you have Google reviews, like we allow testimonials to go on your website, so you can post, you know, your positive Google reviews. I mean, I don't know anyone who's going to post a negative Google review on their website, but you know, the Google reviews are their own kind of thing. And there's even been reports, like I know CBC did a story where a lot of the Google reviews are, you know, were faked. There's a ton of stuff where people go in with ghost accounts and go in and they type a whole bunch of kind of stuff in, and both positively and negatively. You've heard stories of some companies who got hammered, you know, with, you know, a whole wash of negative reviews that nobody even attended their restaurant or even bought their product, but all of a sudden they've got this, you know, huge kind of like, you know, influx of crap reviews because maybe a competitor has decided that, you know, this is a strategy for them to gain a bigger share of the market. So yeah, you can, so from the college side of things, you can post your Google reviews as long as they're not in opposition to the standard practice. But one of the big things is, yeah, you can't yeah, you can't use the best in, or you can't even use that term because it is in direct opposition. Call it superlative language, and those things are things that we've kind of removed from advertising and PT.
Definitely. And I think like me and Jacky, will, like we decided to run an ethics seminar. So you can't imagine we're two very fun people, but we'll sit over dinner and a Diet Pepsi, and we'll say to each other like we should have secret shoppers. Like the association or the college, like if we want to be using terms like best physio in the city, we should be sending one into these clinics and saying, well, did they get informed consent? Did they explain what the literature says on this problem? Were they super thorough with their assessment? So then, like, sure, if those are our metrics, we can start to play that game. But like, if it's in the hand of a patient who has seen one physio and that physio gave them a high five and they really liked that, I don't know if we can call that best.
Yeah. Any final comments on that one, Jackie?
No, that's it.
All right. All right, moving on to sticky note number 3. A clinic double books their physiotherapist and assigns them a kinesiologist. Kinesiologist sees exercise-based patients and the physiotherapist checks in. These appointments are billed as physiotherapy. So we'll quickly check the poll and see kind of where people are at with that one. No, it was kind of like 88 to 12 in the yes to no. Yeah, Matt, you want to start us off on this one?
Sure. Yeah,
What are
like
your thoughts?
this one surprises me a touch. I think we had a better split at for all of these we had a better split at AAP in Canmore.
Yeah.
But in any case, I think this is a pretty common practice. Like I think this exists quite commonly, and I think that you can pull this off in a super reasonable way. I think that if you have made a concerted effort to ensure that you are seeing all of your patients, you are assessing all of your patients, and then you are delegating to a very qualified other professional that you have deemed as competent. I think this is something you can pull off within college guidelines. I think that there may be some behaviors in the community that don't necessarily pull it off with quite the level of supervision that I think would be required. But yeah, like if we look at the literature on exercise and generalized exercise and multidisciplinary care, I give exercise a lot, but I have some strength and conditioning coaches that I work with that are way better at it. So if I can do my piece, the piece that I'm really good at, and that's assessing and determining where someone needs exercise, and then I have a teammate that can do the rest. To me, that's a good patient care model. It's just a matter of patient comes in the door, I wave at them from the corner doing needling on a different patient, and then that's the extent that I see them. That gets pretty nasty pretty quick. What do you think, Jacky?
Yeah, kind of same idea, right? Like, like the idea of delegation, of course we do that, right? That's just efficient use of your time. I think some certain elements of the question just make it feel a little bit more like it's like a physio factory. You're just trying to maximize profits, right? The idea that you're double booking, like you said, where you're kind of just standing in the corner and really not doing anything at all. And so that I think that's probably why we have that big skew in there. But I definitely think there's sort of a gray area in there. Like even think about some of the models we're going to be using for things like tele-rehab, where you really are delegating to someone who you trust and they're going to do their thing and you're not there, right? So yeah, I think parts of the question kind of made it swing really far one way, but I think there's definitely a big gray area in this one. But I totally see why people would be quite against it, because there's definitely that room where it just goes too far and you're no longer really giving physio at that point.
Yeah, I think kind of again like the when you're assigning, so as like a written this a lot, so it's, and apologize, but it's assign, not delegate. That's just the language that we use in kind of legislation. So anyway, so yeah, I agree. Like this is, I think, in some instances can be not common practice, but we assign. But there is that expectation of supervision. There's a ton of expectation around assessment, reassessment, monitoring, and then that difference and again, we get these questions lots about differences between direct and indirect supervision and what does that look like. I think kind of we have a video that's just going to be coming out, should be in the next week or so with the next newsletter, and it really is all about kind of this kind of question, like assessing, reassessing, and monitoring, like the support workers that you work with. And I agree with Matt. Sometimes you work with really great people who have a fantastic skill set that you can kind of lean on with patients that are appropriate. But the way the question is framed, I think it really is that idea is like they're blanket double booking. There's not like oh yeah, you're appropriate, you're not appropriate. It's just like, yeah, we just double book. And then you get a kin and you get a kin. And then yeah, for these ones I'm gonna check in, but obviously the question we don't go into how you could do this, not this specifically, but I mean, there's nothing wrong with assigning exercise to the people that are competent to perform it. I think it's more so that idea of what this question potentially represents, which is practice in which clients are just getting shoveled across into support workers in order to increase your bottom line. And that's not kind of the purpose. I mean, the purpose is always to provide really good quality care, and sometimes that quality care is the exercise support staff has more time, potentially different level of skill set or a different kind of um, you know, bulk of work that they've done where you feel comfortable, be like, yeah, you can take them through this, you can take them through that. But it always comes down to that assessment, and supervision kind of components.
Definitely. Yeah.
Yeah. Have you guys worked in clinics where you have, Jacky, I think you've worked mostly kind of public practice, but Matt, have you, like, for you and your experience, like, have you, worked quite a bit with in which this can be done well?
Yeah, I think so. I mean, like, I have private practice experience where I've worked very closely with a kin, and then I have like some PCN experience where my primary role was assessment. So I would assess the patient, and then to an exercise physiologist, I would hand them a treatment plan. That works really well. Like that is great because that exercise physiologist, from a purely exercise treatment perspective, they have the same scope as me. So if I give them a list of deficits and I say, hey, like this person has knee osteoarthritis, they need to be stronger, they need to be moving more, they need to exercise, I can hand that off and that can stay handed off. It's really nice when I don't have to put a bottom line because Alberta Health is not specifically paying for physio, they're paying for that person to get care for their knee. When I was in private practice, again, I don't think I ever had a situation where I would be double booking, but a lot of my patients saw my kin. A lot of my patients saw my kin. And just from the perspective of like we still need to keep the lights on. Like I need to see a certain volume of humans. I can book in a certain amount of time. But there was always a big element of consent, so it worked really nicely. And there was also a big element of like, I am involved in every single patient that comes through the door.
Yeah. And so we do have a question I think is pertinent to this, so we'll just kind of answer it now. So the question was whether the physio should be better at prescribing progressing exercises than the kin that they work with. I think I'll kind of put in my college 2 cents, and then you guys can kind of also kind of chip in. For me, I think kind of it really comes down to like in the standards, like the PT, the supervised support worker must be competent in the tasks that they're assigning. So if they're assigning like strengthening for, the post ACL patient, and then that patient's progressing, and then they get to the point where, they want to do exercise stuff that I'm not competent in, say like at some point, I don't know, say they want to get back into powerlifting. I don't powerlift. I couldn't teach you, the clean and jerk or anything like that, properly. So that's outside of my competence. And at that stage too, you're like, well, this is now progressed to where it's not really PT. Like you're now kind of like starting to get into where it's just back to activities and things that you really love. And that's outside my ability to really supervise properly. So that's where, for me, I would say goodbye to that patient and, come back if you need me. But I do think like it is important to kind of remind yourselves that, yeah, that you can supervise in things that you're competent, but once it moves outside of your competency level, like it's no longer kind of something that you can really appropriately supervise. I don't know kind of what your guys' thoughts are on that. Because I mean, we do work with some brilliant support workers that do know a lot.
Yeah, I mean like my big piece is I'm always pretty hesitant to say that as a physiotherapist, who sees, to be fair, many conditions that I see are caused by deconditioning or direct trauma, and I am building someone up from zero. I am very hesitant to say that I am better at giving exercise than an exercise physiologist or a kinesiologist who just does that and has done a ton of professional development in that. So I'm probably better for a subsection of my patients. I'm better for that acute care. I'm better for those early patients. But I agree, Sean, there gets to be a point where they're going to be better at prescribing those exercises. And my courses are needling and vestibular care and physio courses. Their courses are like, how can I make someone box jump better? So like, I think it breaks down walls if we can position ourselves and say, like there are physios out there who are also amazing strength and conditioning coaches. Don't get me wrong.
Mhm.
But if we
Yeah.
can position ourselves in and say like, well, we're really good at a lot of things, but we probably need to get away from the conversation of like, we're better than all of our kins. We're not better than all of our kins. I think we have a better business model and we have a larger population to help. But I think it's just a different human that we're dealing with. What do you
Jackie,
think?
any last words?
Not about that, but I did want to mention one thing, just because I wasn't just I hope it doesn't require mentioning, but like just in our some of our discussions here, it sometimes does feel like we're talking about, profit versus like best care, and that's not necessarily the case at all, right? Like you can absolutely find unique ways and creative ways to increase your revenue without crossing lines, but that financial incentive is always is when it's there, it can kind of make things a little bit tricky.
I agree. Yeah, I think kind of it's good, yeah. I mean, a lot of these questions, I think even too, some of the ones that are coming up, like it do involve like a level of financial conflict of interest. And, this is the nature in some ways of private practice is you do, like Matt said before, you need a certain patient volume to keep the lights on. And, in order to kind of provide good care, you need to be in a position where you can actually like financially afford to provide good care. But I agree, like you still have to, look at how to do that kind of within you know, the regulations and the expectations that are out there. Okay, we'll head on to the next one. So I guess this just rolls right into kind of the next one anyways. So physiotherapist has a certification in strength and conditioning. They often transition patients to long-term exercise programs that are then monitored weekly for years. They're billed through insurance as physiotherapy treatment. Could you bill this as physiotherapy treatment, or what really is this? So poll, we're kind of 85-16 kind of on the split, or 84-16 on the split. Yeah, Jacky, you want to start us off?
Yeah, sure. Like this is actually another tricky one, right? Like I think within the context of what we do right now as physios, it does seem like it's out of our scope. Kind of related to what you're talking about, Sean, where if they're ready for this sort of thing, it's time to move them on to the next provider, someone who's just better suited for that, and not because we wouldn't really classify that as physical therapy. But like I don't know, like we make so much efforts to talk about preventative care and how do we keep people healthy, and that seems like this has such a nice role that kind of fits in there where we might hang on to patients a little bit longer and kind of optimize them a little bit further, just so that we are kind of preventing potential future problems. So I can totally see a solid argument for this being okay, but I just knowing how our current system is right now and what sort of our role is within that system, it doesn't seem like it's going to fit. It's not going to work.
Yeah,
Huh?
I think that's yeah, Jacky, some excellent points, and I've heard it argued like dentists. A lot of successful dentists out there that will just say, "Oh, well, you better come back and check in." And like it's pretty accepted practice. Like it's I don't know anything about dentistry research or if I have to go back every 6 months, but I get that card in the mail that says you need a checkup. So like I think that's very tempting for physio to play with. I think that as long as we continue to be very muddy on the word prevention, this is a very hard topic because if I'm saying like, yeah, like, hey, we got rid of your rotator cuff tendinopathy, now let's prevent it from coming back. So you'll come in and it's going to look exactly like strength and conditioning, and by the book, it's going to be strength and conditioning. But I'm saying that as a clinician, I'm calling that a preventative program. And the literature doesn't really tell us either way if that's like me spewing BS or if that's true. So yeah, this gets like I don't envy the college for these like dual license questions and like determining if someone's committing insurance fraud or not. Because that's very, very hard.
Yeah, and we have, I'd say in the last year and a half, put out quite a few resources on trying to like really give PTs like guidance on what meets the standards and what doesn't, and what meets, those expectations in the code of ethical conduct and what doesn't. And again, like I think, part of it lies in like really what is physiotherapy. I mean, to be physiotherapy, you have to meet the standards. So you have to assess, you have to reassess, you have to have a treatment plan, you have to have, all these things in place to ensure that, you're fulfilling your requirements. But I agree, like again, like the question before is like you can do some of these things if you do them well. But I mean, again, like just the way that, that question was phrased is basically that, monitoring weekly for years, like, if I give somebody, a strength and conditioning program after the rotator cuff because they're, 30-year-old and they're still trying to pitch at a reasonably high level, yeah, there's going to be some things that we're going to give them tool wise, but I don't need to see them weekly. I might need to see them kind of once every X amount of weeks, months to, progress to the next level. But really, for the most part, at points you're going to hit a point with that patient where you just, you're doing great. Continue on. Like, here's your program. Like, if you keep up with this stuff, you're doing awesome. If you have any issues, for sure, come back. We'll reassess. We'll kind of, readdress your issue. So again, I think it comes down to the way we're wording these questions, or the way you guys had worded the questions, was to really kind of like shift it towards that, like, yeah, this isn't great because you're missing these pieces. And then I think kind of the other part, and to go back to kind of the previous question, is you brought up the insurance thing. And yeah, like, we're all aware, kind of those of us that live in the private practice world, of the, insurance companies starting to look at pulling funding because of that over reliance on support workers and not enough kind of reassessment or monitoring, and, PTs not being as in touch with their patients as they need to be, or kind of skewing things a little bit too far to that one side where insurance companies could come down hard on it. So it is something for, I think, PTs to keep in mind as they look at, how do I do this? But like I said, like at college level, we've kind of put out quite a few resources to really kind of distinguish between, your strength and conditioning work, which isn't related to a PT problem, and your stuff that is related to a PT issue. And hopefully that kind of creates a really clear delineation for PTs. I just have a question that came in. So, yeah, so actually I kind of answered a little bit. So basically, like, does it get to a point where is it out of our scope to prescribe exercises? And I think when we look at our scope of practice in the legislation, it really it comes down to like treating having a PT diagnosis that you're working off of, and that's, I think, what really kind of a lot of this kind of relates back to. What do you guys think to kind of those kind of comments, or kind of what I had said?
Yeah, I mean, like three quarters of what I do and what I preach my students to do is prescribe exercise. I think that, yeah, I think there's no doubt we are experts in prescribing exercise, and we're experts in movement. I don't question that at any point. And you know what? Like I had a patient today who was doing hang cleans and box jumps. That was in the hopes of giving him the requisite strength so he could return to function. Yeah. So for me, the line between physio and strength and conditioning, have I done any discharge planning? What is my goal? I am not telling this patient that, like, hey, sign a 3-year contract with me. You can come back every 2 weeks.
Yeah.
So like those are the subtle differences, because realistically, if someone came in from space and said, wait a second, Matt has that guy in a squat rack. That guy looks super strong. What's going on? Why is he billing this as physiotherapy? I think that discharge planning piece and that kind of pathological within my scope approach, I think that's what makes the difference for me.
Jacky, anything else to
No,
add?
no, yeah, no, nothing to add to that one.
Yeah, I think kind of in the end, I think, we've kind of figured out, it depends on what your goals are and your goals of care. And, if your goal of care is to get jacked, that might not meet the PT kind of requirement. But, if your goal of care is to go back to powerlifting at the Olympics, then for sure you're going to have your guy in the squat rack with a whole pile of weight as you kind of monitor what he's doing, and, kind of work through whatever, knee, hip, back issue that he's dealing with. So I think it really comes down to just being, I think, honest with what you're doing kind of with that patient. Okay. Next one, physiotherapist who works in the hospital discharges their patients with instructions to go to a specific clinic that they trust. Polls on this one came back 88-12. So actually, I'm kind of surprised. I thought that one would be a little bit more evenly split. So yeah, Jacky, you work in public practice. What are your thoughts?
Yeah, for sure. Like I agree, Sean. I expected this one to be a little more split. I think they think our guests think you're tracking all their answers or something. Something's going on here. Yeah.
You're
But
all
yeah,
gonna
like
get
I
like
could
hidden emails from the college.
no, for
I know
sure. They're
two
like, I'm not
answers.
touching that one. But like, yeah, because like if you're thinking about like I can totally imagine the fact that if you have a patient and they have specific needs, to just say, go see a physio. Like that is not necessarily helping them at all, right? Like they're just going to go to the closest clinic, and especially if they have specific needs or they're a little more complex, you start thinking about narrowing down that list. And I guess the thing here is you're not just narrowing down the list, but you're actually narrowing down to a single person. So I can see where there's a concern there. But like it or not, there's going to be physios out there that we're not happy with how they're practicing. We don't think that their philosophy doesn't align with ours, and we may have certain needs for our patients. So I can absolutely see a rationale for saying, you know what, based on your condition, this is where you should go, and I think that's kind of the best bet for you, right? Obviously, there's that other side, right? Like you can just send it to your best friend, doesn't matter, or you can send them to yourself even, right? Like, and the conflict is pretty obvious there.
Yeah, there's clear conflict, right? Because the other piece about physios is we all, at least like coming out of the U of A, my experience is like I had 110 really good friends. So I want to see them be successful. And if I go work in the hospital and I know that I have a high volume caseload that's going to get discharged that needs community care, well, heck yeah. Like I know where I'm sending you because my buddy will take me for beers later. So like it gets blurry really quick. What I will say is like, this is a very common practice with the ortho specialists that I work with. It's very, very common that they will say, hey, I've sent 15 people to this clinic and they've gotten IFC and heat. I've sent 15 people to this clinic and they've gotten a perfect rehab protocol. So you're going to this clinic if you want me to do this surgery. So right or wrong, this stuff exists out there. And I agree, Jacky. I think that there's like I think we need to look in the mirror sometimes as a profession, and we need to address the fact that we have such massive disparity between what our treatments will be for the same person for the same condition, which sucks. So yeah, I definitely see how you could go tumbling down a very slippery and steep slope with this, but I also see how if your primary goal is patient care that fits that patient directly, I could totally see it referring specifically in an ethical way.
Yeah, and I think kind of for us in the college, when we look at this, it really comes down to, I think, removing that conflict of interest. So yeah, if you're sending them there because it's your spouse, or you're sending them there because it's your buddy, and you might get some sort of like a reward for keep sending people there. That's one thing. But I think really kind of, if your recommendation is based on kind of like clinical judgment, clinical evidence, like, yeah, people I send to this guy seem to do really well, or to this clinic do really well. I know they get, much better level of care, then it makes sense that you want to kind of slide those patients to where they're going to be successful, or where you have, I guess, higher level of faith that they're going to be successful. For us, though, it comes down to that transparency piece too. So usually kind of when we look at discharging patients, like the college's kind of, viewpoint is like, oftentimes you have a list, this is the area you live in, there's 5 clinics that are near your house. Honestly, like, you can go to any one of these, but, I've had really good success with patients that I've sent here. Or, I know this person here has done, multiple courses in vestibular care, and, we're discharging you with some vestibular issues. So in this area, like, this might be someone that, you might have more success with than, these others, but you're free to go wherever you want. And then obviously, if you do have a conflict, you want to disclose that, like, this is the clinic that my best friend growing up in, works at, and, just to give you a heads up, like, but I do know they do good work. And so I do think like it comes down to that disclosure thing. And that kind of transparency part. And then other than that, like, if there's no conflict of interest, again, here's your list, but yeah, this is who I send people to because of A, B, C, D, and E. So again, like a surprise, kind of, we had such a, not, I guess, as much of a split, but maybe, I guess, people are, the way we word questions kind of really drives it that one way. Just I did have a question I'll pose to you guys. And then we'll see kind of how you answer it. So is it ethical to recommend a clinic you do not trust? Your reputation is tied to recommendations. That said, try and give, 3 options and some that way. So thoughts on kind of if your choices are limited and you're like, oh, like you're heading to I live in a small town, so I mean there's very limited options for who you see. So I mean if you don't really have, somebody who are like, cool, yeah, they're really good, you should go see them. You're just kind of like, okay, like I know there's this clinic, but I wouldn't send my dad there. So now what do I do? Do I still recommend them as an option?
Right,
Yeah,
that's a great way of kind of framing it. Like so, if I'm understand the question, it's almost like okay, you want to be fair, so you have a list of clinics in Northwest Calgary, and and you kind of feel obligated to just be like, all right, here's a list and go for it. And there's like one clinic in there where you're like, I don't want you to go there. Is that kind of where you're getting at? Exactly.
I
So it
think so,
almost
yeah.
feels unethical to send them there. I could absolutely see that case totally. When you're thinking of what's the best interest of the patient, yeah, I would feel very compelled. Like I could totally understand someone saying, you know what, here's the list and putting a big X through one name, right? I don't know.
yeah, I 100% agree. I think that I think that was Kim. Kim makes just an excellent point there that if you flip that coin, the other side of that coin is if I don't make recommendations that I think are in the best interest of the patient, perhaps that's unethical. So it's a super interesting way to turn that around and approach it the other way. I agree.
Yeah, I think there's too, like when, we do get these kind of phone calls and emails sometimes where, a PT is kind of writing in, they're like, well, I had patient report to me kind of that this was their experience at this clinic or this PT. What do I do? And oftentimes we're like, go talk to that PT, like let them know that, hey, just a heads up, like, you don't have to disclose the patient, you don't have to disclose like obviously any like private information, but this is what I'd kind of heard, or this was kind of your patient's experience. I just wanted to kind of reach out and like have a quick chat, and because really like we do have, and I think it's in section C of our code of ethical conduct, like we do have responsibility to kind of like point out kind of poor practice and like approach PTs when something's kind of gone wrong to kind of let them know because maybe they're unaware, maybe kind of they do need a nudge in the right direction. But yeah, when you have those experiences where you've had multiple patients maybe kind of have poor experiences at a clinic, it's a really hard conversation to have, and it's a conversation I'm sure none of us really want to do, but it is, I think, important to kind of, as part of being part of like a provincial, community or group of care, even like within your own community, to kind of just reach out and be like, hey, like, this is what I've been noticing. Like, just want to make sure that, the you're aware of kind of the outcomes that are coming out of your clinic. So yeah, might be something that you can do other than just putting the big red X through the clinic and be like,
Mhm.
don't bother. You at least be a bit more proactive and kind of help kind of bump us all up a little bit.
No, for sure. But that X, like that's a lot easier to do than that's a big ask, Sean, to go to a
Yeah,
clinic and
it
be like,
is.
hey, by the way, like that is hard. I get it. Like I
It's
talked
so
about that in
hard. Yeah.
class, right? And be like, this
Yeah.
actually is a professional obligation, but it is tough. But whether it's, our the culture we've created or whatever it is not an easy thing to do though. But hey, if we're gonna complain about it and think that, our standards should be higher, you got to do something about it, I guess.
Yeah. And like I said, nobody nobody wants to have that conversation, but it is it is something that I think kind of is, in the ideal, like in the ideal world, like that's kind of what we're looking for, right? Is kind of looking out for each other and kind of ensuring that people are aware of what's happening.
Yeah.
All right, sweet.
Sorry, just
Yeah, go ahead, Matt.
I don't want to completely belabor the point, but I don't think there's a clinician here today that hasn't had a patient lack success under their care and probably should on them somewhere else. So I would expect and I would appreciate and I would respect if a physio was really worried about how I treated a case. I would love my phone to ring. I really would. I would hate to make that call. Like I would hate to call a physio because I'd be terrified about their response. But I would love to receive that call where someone says, hey, like you were with this patient for 3 months. They didn't get better. They said you didn't give them a home exercise program. They said you didn't give them any education. Like, what happened? And then I have a chance to say, oh, yeah, like they said that they had zero time to do a home exercise program or whatever the case was. But I think we owe that to each other. I think we just need to like love each other just a little more. I think competition gets in the way of that a little bit. Like we are competitive people, we are vying for business in a smaller practice, but man, just like give people the benefit of the doubt.
Okay. Okay. We're coming towards the end, so we'll get through kind of into the next one. Clinic is in the practice of booking all 21 in protocol appointments for all patients who have been in a motor vehicle collision and qualify for WAD 2 funding. They schedule these appointments at the very first visit. So going back to polls, and again, like, yeah, pretty much 88-12. So a lot of people kind of feel the same on this one. But yeah, I guess kind of throwing out to Matt, kind of thoughts.
Yeah, I mean, this killed me. Like it's hard for me to play devil's advocate for this one because this just really bugs me. So it's step up on my soapbox a little bit. I mean, if we heard a physician doing this in the community, or a nurse practitioner doing this in the community, saying that, oh yeah, you're going to need to see me this number of times at this interval, and we're getting that on the books, like you would be appalled. But this is something that happens quite regularly. So I think my standard is that I'm doing some element of assessing at every appointment. And then I am basing my follow-up with that patient on my assessment findings. So yeah, I don't think this is in the best care of the patient. I don't think it's good practice. What do you think, Jacky?
Oh, how about what if they're just, it's for scheduling wise. It's just for convenience for the patient. Just because I've booked them for 21 doesn't mean I can't cancel later. We're just talking about convenience. Anything there? Give me something.
Totally. There's a lot there. So like if you book someone for 21, first of all, it sends a very clear message to your patient. It gives them an indication of what you think their prognosis is. It positions you in saying, you're going to need to come see me that many times over that period of time. The other thing is, if you said that to me and say we were colleagues or one of us was a mentor-mentee relationship, I would say that's awesome. That's awesome that you do that for your patients, just from a convenience and scheduling perspective. Can you pull up 5 patients that you've canceled their last 11 protocol appointments because they've gotten better? And if they say, oh yeah, like I ditched this guy because he was 100% after 8 appointments, and I ditched this lady because she was better, then I'm like, wow, like great, cool. Then that to me aligns with my ethos.
Right.
Yeah, I think kind of it is something that, again, in some of the seminars and courses as a private practice clinician I've sat in, it's that like get that treatment plan like set up, like scheduled, like get it to the patient, hand it to the front desk so they can kind of sit there and be like, oh, Sean says you want to book in for 21 visits, so we're just going to get those all scheduled now. And so I do think it is something that for sure has lived in kind of that world for a long time. But I agree kind of, obviously with Matt, I don't think it's in the best interest of the patient. It kind of creates, I think, expectations, and it complicates matters when it comes down to canceling appointments at later intervals and rescheduling and kind of trying to keep that idea of like the patient comes first and in their care. And I think too, it also sets up the patient to be potentially like locked in where they feel like that I've committed to this, like, well, I better show up to all my appointments, which also kind of takes, I think, the client perspective and the client needs kind of out of things, and probably will promote some unnecessary services from occurring. So yeah, so I think kind of, in the end, like there's not a standard that says you absolutely can't do this. But I do think kind of it definitely, creates certain perceptions which we may not want to have with the clients in our care. And then again, like it is like I agree with Matt, like if you're consistently demonstrating that all those schedules are getting altered and whatever. I mean, the other thing is nothing wrong with booking just the first like couple weeks out in advance and then continuing on with like a discussion with that patient about the bigger expectation that, this is how insurance works. You're, WAD 2, this is your protocol. We're allowed 21 visits within the next 90 days. I don't know if we're going to use all those visits, but that's what we have allotted to us to use. Let's book the first like 2 or 3 weeks out so that, I feel like this is really what you're going to need. And then after that, we can start to, modify and make changes as we need. And I don't know if we'll use them all. Maybe we'll need more. But, I think there's a lot of ways you can do this with keeping, I think, the client's best interests at heart. Okay.
Yeah, that makes sense.
Yeah.
And I think Matt, I don't like your follow-up questions, Matt, so I'm putting an X through your name on that list now.
That's a big hit for the student clinic.
There you go.
Shoot. Well, we'll keep it between us and the 50 people that see this.
Okay, so we do have a couple questions going back to 3-4, and we are getting near the end, so we're gonna kind of head towards wrapping kind of this section up. So going back to scenario 3 and 4, we did have some questions that came in kind of looking at like other things other than exercise. So if say you're doing maintenance stuff using IMS or a different type of like needling modality, you know, manual therapy, etc., like using that as your maintenance, your proactive. In that scenario, like do you get to a point where you eventually discharge patients rather than ongoing maintenance based on their progress? Does it differ, using something that's not exercise?
Jacky, you got to start with this one.
Okay, so what I'm is just to make sure I'm getting the question. So like so maintenance doesn't require exercise, but it requires some of your other like passive treatments and that sort of thing. Yeah, that opens up a huge can of worms, right? The idea of, where do our passive treatments fit into physical therapy? And many people would argue that that wouldn't even qualify as physical therapy when if they are just coming in for some needling and maybe some pain relieving modalities, do we even classify that as physical therapy? And that's a tricky question and one that I think gets challenged quite a bit. So I almost think like that's even worse. Ugh, I don't know.
Yeah, like my immediate gut reaction is nausea. Like um it is the effort to make or I guess it is a situation that is going to make your patient extremely reliant on you. So I haven't read an ounce of literature that says that dry needling is something that needs to be conducted long term for a specific patient pathology. I don't think that exists, or not that I've read. Now it's different if a patient comes back and has a myofascial pain and gets a ton of relief from from dry needling. Yeah, like if you're in a ton of pain, if you're in a pain crisis, come back in 6 weeks. But I'm insulating this with next time I hope it's 8 because I need you on your exercise program and I need you doing the things that empower you to make you better. So I think that if you couple it with really effective physiotherapy, then I think that's great. But if someone's booking, they're like, oh, I have a 3-week on the week appointment where you're going to hammer my traps with needles. I don't like that, but that makes me feel gross.
Yeah, those ones I think are again like just speaking as a clinician, like it is hard because I think there is times where you fall into that trap where you have a patient who gets relief from what you do and they come back and they're like, yeah, it felt good for X amount of days or weeks, and then yeah, it's just kind of keeps recycling back. And and we do get these patients where like, well, have you been doing your exercise? They're like, nope. Like it's I don't have time, I don't want to do it, like this is what I want. And I think those kind of create because I know like the right answer is you're working to discharge them, you're working them to set up with like self-management programs. But it is that challenge of convincing that patient, be like, like, no, like we can't keep doing this because there's no evidence that's showing that it's actually making you better in the long term. You're just coming in, but it's hard to argue with the patient who's autonomous and can make their own decisions. And if that's how they want to spend, their healthcare funding, then, you have that kind of balance to kind of make. But, in the end, like, you have to be able to justify that. And, say insurance company comes calling and they're like, can you justify your, 57 appointments that you saw this person for last year? And you're kind of like, ooh, like, your chart note says like as previous, as previous, as previous, like that's where I think kind of the issue a lot of times with those discussions are like maintenance and proactive and seeing patients for longer periods of time is, can you justify it? Like if you were sitting in front of a group of us and you're like, well, this is what I was doing, like would you feel good about kind of like describing like what you're doing for your care? And we all looked at your documentation, or kind of like, when was the last time you reassessed this person? Like, like that's, I think, where it kind of, ends up for whether it's, not to, harp on, I know IMS is in the question, but whether it's manipulation or, modalities, electrotherapeutic devices, like, really kind of, I think, the argument, I think, equally covers all. And it also kind of put exercise in there too. And, if you're not giving people the right exercise or they're not progressing, I mean, you still have to have that honest conversation with yourself and, are they actually doing what I'm getting them to do, or am I giving them the wrong things to do?
Yeah, I had this argument with Dr. Jeff Bostic, who's a faculty member with us, and he's a pain specialist. So I take a pretty blunt approach, and there's pros and cons to that. I fully understand that my approach with patients has weaknesses. I'm sure some of them will get pointed out in the chat, but I have a saying that I say that, like, this is healthcare. This isn't McDonald's. So you don't get to come in and order a number 3 with a side of IMS. You get to come in with a problem, and we get to work through that together. Now, you could immediately make the argument and be like, well, Matt, if this patient really wants, like, let's say IFC, doesn't that give you an opportunity to try to educate them and then you have time to convince them to do the exercises? Absolutely. There's huge value to that. That's a thing. But I think that as a profession, and again, if we compare ourselves to our medical colleagues, it's their job to educate and do what's in the best interest of the patient. So if the patient comes in and wants Percocet, sometimes they'll get Percocet because it's in their best interest. But a lot of times it's, well, I don't know if this is a good idea. We should tailor your treatment plan this way. So I really think that that passive care, that recurrent passive care is a really good opportunity. And I think Jesse in the chat, I probably have to quote you and steal you on this in any lecture I give, but if goals of care are improving quality of life, physical function, or mobility, I would argue strength and conditioning program is appropriate and can be applied to a large majority of patients. I think that's just absolutely brilliant.
Might be a good place to leave that. Okay. All right. So kind of come to the end. I think we have no more questions. We'll give last chance for anyone who wants to post something. While we're waiting, if anybody else wants to pop something in, we'll kind of end there, I guess. Looks like nothing else is coming down the hatch. So,
Sean, can I say something?
yeah, absolutely.
What a disaster. This is brutal, Sean. I didn't even realize this till now. So we probably should have said this in the beginning. We are not clinical ethicists by any stretch of the imagination. This is honestly like this, like when we go into our seminars with students, this is what we do. We talk, we hear opinions. Very rarely, we may redirect and be like, all right, there's certain rules we need to follow, but we are not there to say this is right and this is wrong. Very rarely will that come up unless they're really offside. But really, our job is to facilitate discussions, bring out the ethical principles that are important to healthcare, but we are not saying we know the answers. Maybe it's a bit late to be mentioning that, but there we go. At least it's on the record somewhere.
What do you think, like, for you guys, it was great to have that discussion and kind of be able to kind of play devil's advocate and punt ideas kind of back and forth. That being said, I would say, from a college standpoint, I mean, we do have some very clear guidelines in which we're trying to push PTs to kind of be aware of and, think about, be conscientious of as they make those clinical decisions in their day-to-day lives. I mean, we're not there to nudge them, in the middle of their day for clinical practice and be like, yeah, I don't know, like you should be doing that. But really our goal is to provide resources and to kind of give people real life kind of scenarios in which they can kind of think about the things that actually occur in their practice. And, again, like we get questions that are repeats kind of over the last, X amount of years. Some of these questions recycle. So then we try and identify and provide resources to help PTs just identify kind of really like, is there a line and which side of that line do you fall on? So I get that we're not ethicists at any stage, but, for us, I mean, the whole goal of this was to really kind of define like some not right and wrong, but definitely like some, yes, this is within the standards of practice and your legislated requirements. This isn't. This is kind of a gray area. You can do it well. You just need to keep in mind like these things. And I think kind of questions 3 and 4 really highlighted that, like, and 5, I think even too, like, you can do those things if you do them well and if you have structure in place that allows you to kind of, do it as like being a decent human being. We did actually have one last kind of question come in. I'll just answer it. It's pretty straightforward. So is it difference if you say you're the best PT or if you were voted best? And again, it's the votes. We don't know where the votes come from. So again, like whether you're voted best or you're just claiming you're best, to us, it doesn't really matter, because in the end, kind of the fact is that we don't know who's voting. We don't know the parameters of what that's happening. And so you can't really be accurate or verifiable in those statements. Okay. All right. So we'll pause there, and we'll thank Matt and Jacky very much for their time. And I think kind of we'll thank the AAP too, because they brought you guys together and did a really great job at the conference. So again, big thanks to you guys for coming out today and reviewing all this stuff with us. So thank you very much. Thanks to the audience for